Good morning, everyone. I'd like to ask everyone who's not in a seat yet to take one. We do still have a few around the room. And I'd like to welcome you on behalf of the Brookings Engelberg Center for Healthcare Reform and the Dartmouth Institute to today's event on achieving better care at a lower cost through accountable care organizations. The Engelberg Center and the Dartmouth Institute for Health Policy and Clinical Practice are very enthusiastic about convening this event today. I'm Mark McClellan. I'm the director of the Engelberg Center for Healthcare Reform here at Brookings and the co-director with Elliot Fisher of the Brookings-Dartmouth ACO Learning Network. We're meeting today at a very critical time for healthcare reform, and we're also meeting today on a very challenging day from a weather standpoint. So I really appreciate all of you braving the weather, not only to get here, but to get here on time. Special thanks to all of our panelists who have come from all over the country, Northeast, West, Midwest, everywhere to be here. And I also want to welcome the many people who couldn't be here in person and are joining us by webcast today. Unfortunately, Nancy Ann DeParle is not going to be able to join us due to some urgent matters related to the situation in the Middle East and her new duties as Deputy Chief of Staff. But regardless of the weather and the other logistical issues, the urgency of the issues that we are discussing here today remains. So we're very glad to convene this timely discussion today. You all know that most of the public attention around healthcare reform has understandably been focused on issues of coverage expansions and their costs, and mandates and constitutional challenges and things like that. Those are certainly very important issues. But at the same time, Medicare and states and private payers and businesses and healthcare organizations, consumer groups, others are all taking many new steps to try to reform the way that healthcare is delivered, to reduce costs while improving health. And that's what I think of as real healthcare reform. And today we're focusing on a critical aspect of real healthcare reform, the next steps in the implementation of accountable care organizations, ACOs. The idea behind ACOs, as I think many people know at this point, is common to many kinds of healthcare reforms, paying more for better care at a lower cost, but not doing so in a way that's too disruptive to current payment systems and the current methods for delivering much-needed care. ACOs are coordinated networks of providers with shared responsibility for delivering better care at a lower cost, and they're accountable for that. They're accountable for that. It's built into the reporting and the payment systems for the organization. The aim behind all of this is to reward value instead of volume and intensity by making providers eligible to share in the savings that result if they are able to take steps that reduce overall healthcare costs while maintaining or improving quality of care. ACOs are intended to provide better support for things that doctors that I talk to every day say we don't do well in our healthcare system today. Coordination and integration of care, investments in important kinds of health information technology, and a wide range of other approaches that get to that bottom line goal of better health and lower costs. The idea is to provide more payments for these kinds of services in return for more accountability, not just for volume and intensity, but for what we really want, better care and lower costs. And something I think is important to note, and we're going to talk a lot about today, these ideas are being implemented now. They're being implemented in some Medicare demonstration programs like the Physician Group Practice Program and the multi-payer Medicare healthcare quality demonstrations in Indianapolis and North Carolina. They're being implemented, as you'll hear, in the private sector and state programs around the country. So what we want to do today is get practical. As Deb Ness said, get concrete. What we're learning from these private plans and states and Medicare demos, what are they telling us about what can and can't be done effectively in terms of ACO types of reforms? What are some other steps that share the same goals as ACOs? Paying more for better care, not just more care or more complications, partial and full capitation plans, medical homes, IT payments, there are a wide range of other reforms. How can these all be related to be sources of synergy to get to better care and lower costs? Now, the Engelberg Center here at Brookings and the Dartmouth Institute have been collaborating for some time to provide tools and guidance and support to put accountable care, as I've just been describing it, into practice to support better care at a lower cost, working collaboratively with providers and consumers and other groups in both the public and private sectors. We're supporting the implementation of 5 pilot ACOs for commercially insured populations right now. We've also started the second year of our expanded ACO Learning Network, which is supporting over 80 organizations around the country through the technical and practical details of the ACO implementation process. And along with our learning network and our pilot sites, we're also leading some more advanced ACO implementation groups, building and conducting ACO evaluations and surveys, and helping to develop and align on accurate, reliable, meaningful performance measures, timely performance measures, as well as providing a number of other analytical resources. One of those resources is coming out today, so we're very pleased to announce the release of the Brookings-Dartmouth ACO Toolkit. This toolkit, which is now available online at acolearningnetwork.org, is about 200 pages of comprehensive ACO implementation guidance based on firsthand experience of people who are working now on programs like this, a wide range of collaborators on this overall effort. You all should have received a sheet in your packet with some more information on the toolkit along with the agenda for today's event. Now today we're bringing together, this is one more step in this process, bringing together experts, policymakers, a number of the organizations that have been implementing ACOs and reforms that relate to ACOs from around the country to continue this work and this discussion. We're going to focus again in some practical depth. We're going to try to get concrete on a couple of critical implementation issues in particular. One of those very important issues is how to effectively engage consumers in the implementation of accountable care. That'll be the focus of the first part of the morning. And the second is on the provider side, how do we support the movement of ACOs to more accountability? How do we actually do this in practice, taking account of all the ideas, all the concepts, all the theoretical concerns? How do we really make that practical and real? To make sure that we're having the right kind of impact from these reforms. So we're going to be hearing from 2 sets of panelists that are going to be exploring both of these critical issues. We're going to lead off each panel with some framing remarks to provide an overview and hopefully get the discussion going, again, around these concrete and practical next steps. After the opening remarks, Elliot Fisher and I are going to help to moderate a discussion among the panelists. I don't think they really need us as moderators very much. These are all experts on both the big picture and the practical steps in their own right. We're going to go into some more detail. We're then going to have a little bit of time at the end of each panel for questions and brief comments from all of you. So looking ahead to that, there are going to be a couple of roaming mics attached to some of our staff in the audience who will come around to you. So when we get to that part of each session, if you've got a comment to make or a question to ask, just raise your hand and we'll try to get in as many as we can as quickly as possible. As I mentioned before, this event is coming at a critical time. The goal of engaging consumers, making sure there's strong incentives in place to encourage accountability and to get to better care are essential if we're going to transform our healthcare system. Officials at the Centers for Medicare and Medicaid Services are currently working on regulations for implementing ACOs in 2012, that is less than a year from now, Dawn, as you know, under Medicare provisions that are going to help encourage this transformation, as well as implementing a number of innovative pilots related to extending the ideas of accountable care through the new Centers for Medicare and Medicaid Innovation. Leading these efforts is Dr. Don Berwick, the administrator of the Centers for Medicare and Medicaid Services, CMS. Dr. Berwick has an extensive professional history of working on ways to improve population health and improve care delivery while reducing costs, the triple aim. And for him, just like for our meeting today, this isn't just about theory. It's about getting into healthcare systems and changing healthcare delivery, changing financing, changing policies to support all of that, all at the same time. Before he became the leader of CMS, Dr. Berwick was president and chief executive officer of the Institute for Healthcare Improvement. He was also a clinical professor of pediatrics and healthcare policy at Harvard Medical School and a professor of health policy and management at the School of Public Health. Dawn, it is great to have you with us today to kick off this event. Thank you.
Thanks, Mark. Thanks for your leadership and Brookings' leadership in helping us think through the healthcare system that we want to progress in our country. It's a constant source of ideas and inspiration to me, and I want to personally thank Mark for his ongoing mentorship. He's a great counselor. You've got a busy day ahead, and I don't want to take too much time, but I thought I would just set the stage a little bit at Mark's request about where we are in the ACO world from the point of view of CMS, and to share a little bit about my thinking and those of my colleagues at CMS about the principles that underlie this expedition that we're on. I'm going to do it by zooming out first to CMS as an agency. That's the part of this story that I now know better and better, while the work you're all doing plays out in parallel and hopefully in synchrony. I'm going to show you the overall CMS strategy that was launched a couple of weeks ago within the agency, and then position the ACO work within that and give you some idea of how this fits into the bigger picture of the kind of work that we would like to do on behalf of our beneficiaries. Upon my arrival at CMS now 7 months ago, I began a series of conversations throughout the organization around our nature, and it was always my intent and has been widely embraced now, the idea that CMS is more than a payer, more than an insurance organization, but rather a steward and partner in American healthcare for making our healthcare system better. And so the vision statement that now guides our agency and our strategy is this, that CMS is a major force and a trustworthy partner for the continual improvement of health and healthcare for all Americans. That's the overarching rubric. It's a carefully phrased, a carefully constructed vision and done in dialogue with my many wonderful colleagues there. A major force implies an agency that's proactive, where we want to actually help cause change in synergy with you. A trustworthy partner means we cannot do it alone. The kind of vision that Mark was just laying out for an ACO, let alone for the healthcare system as a whole, is no longer in any single party's hands. We're going to do this together or not at all. And therefore, the agency, to my mind, has to be a very, very trustworthy partner, breaking down barriers between the public and private sector so we can work very well together on common journeys. Continual improvement means to get out of the check-off mentality, get out of the concept that minima or just doing good enough is good enough. It isn't. The demands, the social needs in healthcare are simply too dire for us to think that way, and we're really going to be in a journey of continual improvement or we can't meet the social need. Health and healthcare is a sleeper. It's a very important issue. Scientifically, as you know, only 10% of the variation in health status is attributable to health care. The rest is either genetic or circumstantial. It has to do with risks in society, behavioral choices, the causes of illness. And I think any party now in American healthcare that is serious about achieving better care at lower cost, which is what we're serious about, is really going to have to engage the issue of health and health production, not just health care production, more authentically. For CMS, that puts us in a partnership with other agencies, CDC, the Assistant Secretary for Health, and others are actually more the lead agencies for health improvement. But I'm trying to orient us all together in CMS toward health, the production of better health, not just health care. And all Americans, it just means that if we're going to work hard to try to improve care for the 100 million beneficiaries in Medicare and Medicaid, and now the 30 million people that will end up being helped through the Office of Consumer Information and Insurance Oversight, it's the whole system in play. We're going to have to do this together in partnership with the whole system, so all Americans now count, of course. I've brought my prior thinking about the three-part aim, we now call it in CMS, as the overarching definition of what continual improvement is. Continual improvement of performance means three things at once that Mark referred to: better care for individuals, really contemplated by the Institute of Medicine, Crossing the Quality Chasm report, safe, effective, patient-centered, timely, efficient, equitable care. Better health, that's what I just talked about in terms of upstream causes of illness. And lower cost through improvement. Here is a matter of great public debate and discourse. Do we mean lower cost through withholding care? We do not. This has to do with achieving lower cost through the improvement of the care system. And I bring to my work at CMS enormous confidence that through imagination, invention, innovation, we can and we will discover ways to give care that are far better for people without withholding anything at all that people want and need through the redesign of care systems. This is the CMS aim. Just to give you a little peek managerially inside, this is what we're working on right now. The agency itself is large and complex and wonderful to deal with, but we, like all organizations, we have cultural challenges. There are ways we have to be in order to be effective trying to help healthcare become what it can be. And so these are the 5 values, operating values within the organization that I'm working on very hard with my colleagues. This is linked now to performance pay for senior staff, and we're going to metricize it this year. And these 5 characteristics, just to give you a peek, are very important, I think, to setting the stage for our ability to help the way I think CMS can help. Boundarylessness, breaking down barriers within the agency between Medicare and Medicaid, between measurement functions and surveillance functions and so on, getting out of siloed thinking, much as healthcare has to do and much as ACOs should be. Speed and agility has to do with moving with the pace of social need. Unconditional teamwork is the idea of sharing resources at a time when resources are constrained. Valuing innovation is willingness to take risks and indeed to fail sometimes en route to better care. And customer focus means an organization that's sensitive to the people who depend on it and judges its own quality in terms of how the people we're trying to help view us, beneficiaries, providers of care, and others. We could spend a lot of time on these, but I wanted to lay out to you my general approach managerially is that values are the underpinnings to excellence. And I think the same will be true in ACOs, frankly. I once heard someone say, when values are strong, rules are unnecessary. When values are weak, rules are insufficient. And I think working on the value structure of our agency, as we would hope healthcare will do, is an important thing to be explicit about. Our strategic areas of focus, there are about, I think, 16 or 17 goals now on our map of strategy for 2011. They fall in these 4 buckets, and you'll see ACOs emerge in a minute from this framework. The first is internal. I like Gandhi's famous quote that you must be the change you wish to see in the world. And I think that's true. And as I just said about values in CMS, I think it's true of our operations as well. If we want healthcare to be seamless, CMS has to be seamless. If we want healthcare to be agile, we have to be agile. If we want healthcare to be responsive to the people it serves, we have to do so. If we want healthcare to be simple and elegant, we have to be that way. And so there's a set of operational characteristics which would bore you for me to get into perhaps in detail, but it has to do with how we work, simplifying our rules and procedures everywhere we possibly can, working really hard on the capacity of our own workforce, the 4,500 people who work there, to improve their work, just as I would hope healthcare capacity for improving care can advance. So that's area 1. Area 2 goes back to the IOM CHASM report, those 6 dimensions: safe, effective, patient-centered, timely, efficient, equitable care. It's trying to organize a lot of CMS work around the needs of particular individual groups in care. Probably the flagship here is patient safety. It's 10 or 11 years since the Institute of Medicine report To Err is Human. We don't have a lot of evidence of progress on safety systemically. We do in pieces, but not systemically. And so there's one example of a goal area under Area 2 is to work really hard on now making, what I'm saying internally is bring excellence to scale. If we know how to eliminate infections in some places, let's try to do it every place. If we know how to make pressure sores go down by 95% someplace, let's do it everywhere. And there's a series of aims I think it's time for us to share at quite a large level nationally, and there's no resistance to this, and I think you will see this year play out perhaps the largest effort in patient safety our country's ever seen. Another area in care for individuals is the amazing possibilities for dual eligibles with the new Center for Duals. It's got a longer and more complex name, but headed by Melanie Bella, a fantastic leader. We can pick up the needs of these 9.2 million Americans. They explain 40% of Medicare costs at a time when Medicare costs are a serious issue, and their quality isn't as what it should be. We estimate 100,000 duals are actually in integrated care out of the 9.2 million. And so that's another area in improving care for individuals. The third is what we're talking about here today, if I finally get to it, and that is the concept of integrated care. I think it's the flagship. I think if I had to really come down to one area where our work intensively could help deliver on social need, it is this area, producing integrated experiences. I'll come back to that in a minute. Now, fourth area is prevention. We're going to be doing quite a bit of work this year on cardiovascular disease and prevention of heart attack and stroke in concert with CDC and others, and working on disparities. I'm working now with our new office, the office soon to be set up for minority health within our agency, picking a few areas of disparity and concentrating on that. But let's go back to area 3. That's what we're here to talk about, integration of care. There is actually a fleet of innovation fronts under the Affordable Care Act, all of which have to do with the creating journeys for people instead of fragments. That's what people need. I'm always returning to the patient in my mind as a guidepost, and several times in the past month I've talked about a patient. I hope I won't bore you by repeating it if you were in some recent talks I've given, but it's a kid that I saw 20 years ago named Kevin. I wrote about him a number of years ago, but he's come back very much to my mind. He was 15 years old when I saw him. Kevin was well, he was doing well, but he was chronically ill. He had a short bowel syndrome due to resection of intestine as an infant. He'd been in and out of the hospital 30 or 40 times. When I was teaching in the children's hospital, my habit was to get together with the medical students and the residents and ask them to show me a patient who had been in the hospital for a while, and I dared them to show me a patient who had not had a complication of care. I offered these underage students a case of wine if they ever successfully did that, but I never paid off. So Kevin was such a case. We went to his bedside, and I said to Kevin, you've been here a lot. What could be better? What could we do better? And he said, nothing, you're just great. And all patients tend to say that right at the start. We're very grateful, and you're doing a good job for us. And I said, no, Kevin, I really mean it. You've been here a lot. Tell us what we could do better. And he said, nothing, I just told you. I said, Kevin, write down what we could do better. So I said 3 things. So he wrote out a piece of paper, which I kept for a while and then lost. And if you find it, return it to me, please. Kevin wrote 3 things on the paper that I distinctly remember. The first thing he said was, please tell me what you're going to do to me before you do it. He was asking for anticipation. He wanted a plan. Kevin wanted to be on a journey, not in little pieces. The second thing he said was this. He said, you got 10 doctors and 20 nurses and 30 tests. He said, you're all wonderful. Could you please talk with each other? That's what he wrote on the paper. Please talk with each other. He wanted us to be a team. It was too complex, the journey he was on, for this to be done in pieces. And the third thing he said was, I've been in the hospital 30 times. I actually know more about my illness than most of you do, and I certainly know more about my life than you do. He wrote on the paper, please ask me what I think. I kept that for a long time because I think he was telling us our job. He was saying, plan ahead, be a team, and put me in charge. Give me power. And to me, when I go back to ACOs or bundled payment or medical homes, and I try to understand what we're doing, I just keep thinking about that kid and people like him. That's what Area 3 is. That's creating journeys. Now, the law has given us this vocabulary thanks to leaders in the room, the Accountable Care Organization, one of several options: bundled payment, medical homes, health homes, Accountable Care Organization. What do we imagine here? I don't imagine the status quo repackaged. And I guess my biggest concern about ACOs might be that if we get it wrong, that's what will have happened. We'll have taken the status quo delivery system that doesn't serve Kevin well, today's Kevin's, and put it under a new name. And that won't be success. That isn't meeting the social need, not better care, better health, and lower cost through improvement. I'm viewing the Accountable Care Organization, I hope, as new care design, created, as Mark said, in a very unusual context, a context of open choice, fee-for-service payment, and the absence really of restrictions, which is a very bold idea and an important idea. If we do that well, Kevin will be well served, and so will our current financial crisis in healthcare. If we do it poorly, it'll be the status quo renamed. The principles that would underlie this redesign are several. These are my own words. They're not in the law, and they're not necessarily what will emerge. But first, it will put the patient and the family at the center. It will honor preferences and values and backgrounds and resources and skills at the individual level, and will engage people in shared decisions about their diagnostic and therapeutic options. This will be centered around the patient, not around the care delivery. It will have a memory. Amnesia is a real problem in healthcare. When Kevin says, please talk to each other, he also means remember me. He means keep the data, information together. Teamwork will now become paramount in the ACO, I imagine. Patients won't have to repeat their stories. They won't have to tell people to talk to each other. That'll happen automatically because now the dynamics and the incentives are in place for people to be a team, which I think they want to be. The third is that handoffs will matter. That's related to that. Patients' journey through the system, and we hand them off, and it's the handoffs where things tend to go wrong. It's these boundary places. The concept of the ACO would be to create a seamlessness that is real for the people who who need us not to drop the baton. Make a plan, said Kevin. Tell me what you're going to do before you do it to me. That involves crafting pathways together. It will have to respect resources, better care, better health, and lower cost through improvement. All three will matter, and we need agents, stewards in American healthcare understand that resource management is healthcare also. And the focus there is not on withholding care, it's on reducing waste. And so becoming sensitive to the nature of waste, wasted time, wasted effort, wasted materials, wasted supply, wasted information, wasted ideas, wasted spirit, and making sure that every step adds value is good for Kevin and good for meeting the social need. And an ACO, to my mind, is a place cognizant of that. And then it will reinvest where investment counts. We now invest in volume and throughput. The ACO will invest in value and outcome, which means resources are moved to where they're needed. And so if there's a need for a focus on anticipation, resources will go to anticipation. If there's a need for focus on pattern recognition, resources will go there. If there's need for care at home, resources will go home. And the ability to move resources around in a cooperative mode is key to the concept. That will, by the way, have a big impact on one important agenda, which is the avoidance of unnecessary and harmful readmissions. When we drop the ball and things go wrong, people end up back in the hospital, not at home where they want to be. That involves proactivity. It means not waiting for things to happen, but preventing things upstream. That allows proactive clinical management with reminders and advice, keeping people healthy, keeping people aware, reaching out and telling you it's time for your test, your checkup, making sure that people know how to get what they need when they need it. And all of this will depend on data richness, something Elliot and Mark have been stressing so eloquently in their work. We need daylight. And an ACO properly constructed will be able to measure and manage what's important for the patient over time and space, tracking outcomes, knowing how things are going over time and space, and transparency is relevant. The lights need to be on. The status quo won't do it, and so we're going to somehow need an ACO economy interested in innovating, finding the better way, and there are so many options now in American healthcare for better ways. I'm particularly intrigued with the modern telemedicine technologies. The more I look at them, the more promise they seem to have, and being able to innovate in that space would help everyone, all the patients we want to help. Electronic health records will need to be key. And so will search. I think an ACO, in my mind, would be a place that scans. We want to do better for people with short bowel syndrome. Who does the best? We want to do better for people with arthritis. Who does the best? For duals, who does the best? And that ability to scan and know is related to transparency, openness, and data. And it has to attend to its workforce. I continue to believe personally that pride and joy in work are the foundation for effective work in any industry, but they're clearly the foundation in healthcare. A healthcare workforce, doctors, nurses, technicians, therapists, managers who are not joyous about their ability and capacity to help people can't help people, not the way they really could if they could discover the pride in their work. And so I think workforce development now becomes back on the screen, I hope, for the ACO, and that applies to everybody that works in healthcare. As we do this, underlying this, of course, are sort of policy aims. I don't have a cogent summary, but to make this happen right, more and more we're aware that certain touchstones need to be nurtured, or whatever, that's a mixed metaphor. Touchstones need to be touched, I guess. I think that concept of better care, better health, and lower cost through improvement is a touchstone. It means that authenticity with the ACO means simultaneous pursuit of those three, at least as a collective. Pluralism of sponsorship matters. It's really clear if you hear the feedback, and we've been all over the country, listening sessions, dialogues, hours and hours, days and days spent trying to hear what people are telling us. And they're saying, really what they're saying is, give me a shot. I want in. A small group practice, a small hospital, large hospital, teaching hospital, a specialist. Everyone kind of wants to be able to play. And I think the policy framework here will create doors, opportunities for people to participate from different sites. That means an ACO won't be one thing, it'll be a collection of models, all of which share in common this core of, that I just referred to. We'll have to honor guidance issues like antitrust matters, stewardship, beneficiary protections, and so on have to be managed. And if we're going to use the financial mechanisms of reward for success, we will have to make sure that we know success. And that means quality measurement, quality metrics, assessment of the patient's status is the balancing measure to anything we do on shared savings or gain sharing. That's the safe terrain. We lose sight of that and we at our risk, at the patient's risk. Now I'm in a little bit of an awkward moment, aren't I? The notice of proposed rulemaking isn't out yet. It will be out very soon. But I can't tell you what's in it yet because I guess I'm not supposed to, but you'll see it soon, and then there'll be a comment period, which I hope you'll all take seriously. But of course, you know there are issues that we're going to have to parse as we engage in this expedition toward appropriate and helpful integrated care. What will risk look like? Shared savings only? Upside, downside? Partial cap, full cap? What would work? For whom? Who could play under each of those different conditions? And what would happen? Beneficiary protections, avoiding cherry picking. The ACO is written in the law, preserves choice. Very important idea. Protecting the ability of the patient to be powerful. Patient attribution, will it be retrospective, prospective? How will we know who's in or out of the ACO? This is not managed care. This is not Medicare Advantage. You don't sign up for this. You're attributed. And how to do that is a tough issue. Measurement. How many measurements? Of what type? What's the balance between process and outcome measurement? Measurement capacity. The tougher the measurements get, the fewer that may be able to play. And finding that sweet spot where we're measuring enough to know and protect the beneficiary, and yet measuring with enough parsimony that we're not excluding people with complexity. Privacy and data sharing. What can be shared, what not? The ACO is going to want to know a lot about the people that are in it. What can they know? Are those people, is it okay with those people for them to know it? Getting the privacy issues correct is going to be tough. Generating capital. If it's not the status quo repackaged, then there's investment and change. Well, who can invest? Maybe large hospitals can invest. What about a small practice? How are we going to find the investment opportunity and create the pathway? Will there be enough security to invest? Is this going to go away in 2 years and it's not worth going through the trouble of the change? The antitrust, Stark issues. We have to maintain integrity of markets and market forces and not let monopolistic behaviors emerge. And then there's this other very interesting and fun area of what I would call accelerated models. The 3022 rule, the core NPRM, will be a core model. It'll be what many can play with. But we all know there are places out there ready to surge ahead to a completely different level of integration because they've been there already or they're en route. And wouldn't it be nice if we could make space for a vanguard who can move ahead of the pack and teach us all where to go? Maybe the Innovation Center, the Center for Medicare Making Innovation, can be a home for that kind of pioneering element on our behalf, on everyone's behalf, not specially entitled players, but our scouts. And that's another issue and possibility that lies there. The core to me is authenticity. As I say, I think there will be parties out there who wish to take advantage of the law and the vocabulary to relabel what they already do and repackage the status quo. I don't think that will be enough, not at scale. We're going to have to find a way to deliver care better, and that means change. And the question we'll be looking for as we migrate into this terrain, it seems to be, is are you really in the game? Do you really want to provide better care for Kevin at lower cost through improvement? Or are you simply taking what you already do and calling it something new, because that's the game today? That's the question I think we'll be facing case by case and probably all together. Thank you again for your leadership and the chance to share these ideas with you, and I look forward to what's coming out of the rest of the day.